I am excited to introduce Dr. Amy Trottier. Dr. Trottier is an assistant professor in the Division of Hematology at Halifax, Nova Scotia. She completed her undergraduate medical degree at Dalhousie University, followed by an internal medicine and hematology residencies at the University of Calgary. She then undertook a research fellowship at the University of Chicago, studying germline predisposition to hematologic malignancies. Since returning to Halifax in 2020, she opened a translational research program and has established an inherited hematologic malignancy risk clinic and implemented clinical germline genetic testing for hereditary hematologic malignancies. Today, Dr. Trottier will provide an overview of hereditary hematologic malignancy syndromes with a focus on those that predispose to MDS and AML. Topics will include who, how, when to test these patients, as well as what to do with the results. She will present results of a large-scale germline genetic sequencing studies conducted on an unbiased international MDS population and highlight ongoing areas of research. Quick reminder to attendees to please place questions in the Q&A instead of the chat. Questions can be placed in the Q&A at any time during the presentation and will be fielded at the end of the presentation. Additionally, a reminder, if you are a CGC member, you must complete the evaluation for your credit, your CEU. The evaluation link will be placed in the chat at the end of the presentation. Additionally, make sure your Zoom display name has your first and last name so that we can verify your attendance for credit. And thank you, and I'm excited to hear from Dr. Trottier.
Thanks so much, and thanks everyone for joining and the invitation to give this talk. So yes, so today we're going to talk about hereditary hematologic malignancy syndromes. And I want to really get across the point that these are more common than we have originally thought, and we'll provide some data as well to support that. So today, as mentioned, kind of a few main take-home or objectives here is first and foremost going to provide an overview of some of these syndromes, particularly focusing on those that predispose to myeloid malignancies such as MDS and AML. Providing the results of a large-scale unbiased population study, we'll review how frequent are these actual germline variants in MDS in particular, and I'll provide a more practical how-to approach for these individuals and suspected individuals on a clinical basis. So we all know and can imagine, of course, a new diagnosis of cancer is devastating and can be devastating. And there are two common questions that typically come up on a patient's mind. One is, of course, why did I get this and why did it occur? And then the other is often, well, are my family members and are my children at risk since I have this as well? And for some cancers like breast cancer, in particular, there's more known, and it's been known for longer, that there is definitely a proportion that is hereditarily predisposed. And from the existing data, we can tell these patients that in about 5 to 10% of cases of breast cancer, they have been found to have a hereditary predisposition. And the genes for which damaging changes have been implicated are fairly well established. However, when it comes to hematologic malignancies, such as AML or MDS, traditionally, we as clinicians have just been instructed to tell patients that we don't really know why it occurs. And in general, your family members and children are not at increased risk and just seems to be more of a bad luck, age-associated things. But certainly times are changing. And as the fields of genetics and oncology have increased, we now know that in a significant proportion of cases that that's just not true and that dogma needs to change. So where did this all begin? Well, it began with RUNX1 and the investigations and initial discoveries that led to this first uncovery of an inherited predisposition to myeloid malignancies began quite a while ago. So back in the 60s was the time when the first autosomal dominant pattern familial platelet disorder first emerged. And over time, we see evolutions in this. So then we started to notice that there are these families with platelet dysfunction and platelet numeric abnormalities that seem to associate with hematologic malignancies. as time goes by in the 90s and technologies improve, we started to narrow down what's the potential cause. So linkage studies first isolated the region on the long arm of chromosome 21 to be implicated with this particular syndrome, these platelet disorders and high propensity to myeloid malignancies. But it was not until 1999 the actual gene was uncovered. So this is what's now known as RUNX1, was identified as the cause of familial platelet disorder with propensity to myeloid malignancies. Well, since that time in 1999, there has been a rapidly expanding, growing germline mutational landscape. So we've had numerous other genes now that have been uncovered and convincingly known to associate with a higher risk of developing these malignancies. And a lot of this has been to deal with the advent of next generation sequencing technologies and their increased utilization in clinic, greater availability, and the decrease in costs over time for the use of these instrumentations. So as you can see here, this is just a number of the different genes for which deleterious changes can predispose to myeloid or other malignancies and a time scale of them. And more of these genes are continuing to be discovered. To this end, globally, this is being recognized as a more and more important phenomenon. The first incorporation in one of the world's major diagnostic classification criteria guidelines was in 2016, when the WHO publication for the 5th edition of its myeloid neoplasms and germline classifications, the 4th edition, was published and included a chapter on myeloid neoplasms with germline predisposition. Since then, now you can see that all of the most recent major world guidelines, so this is including the latest European Leukemia Net guidelines, now the latest 5th edition WHO guidelines, and the most recent NCCN guidelines for myelodysplastic syndrome and AML, all include significant sections of germline predisposition to myeloid malignancies. So that highlights how important these conditions are and that they are becoming increasingly recognized. So what exactly are these? For the next little bit, I'm going to provide a bit of an overview of the different germline syndromes that associate with increased risk of these malignancies. This is an hour section. I want to leave a lot of time for discussion and questions because I think that's really important and how we learn a lot. So I'm certainly not going to talk about all of these. So I've just sort of handpicked a few to give examples, and as well as want to cover one of the most common ones, which would be DDX41 as well. So in general, most of the guidelines, if you look at them nowadays, will break apart these germline predisposing syndromes into a variety of categories. One is those that predispose to myeloid neoplasms without any pre-existing organ dysfunction or platelet abnormalities. And generally falling into this category are CEBPA, DDX41, and some will put TP53 up here, but certainly that can also be grouped in with those that include multiple cancer types. There are also 3 genes which predispose to known underlying platelet disorders. So these would be RUNX1, ANKRD26, and ETB6. There are others for which you commonly see other organ manifestations and dysfunction, and GATA2 is kind of the poster child for this. But you also have our more other known syndromes, so a variety of bone marrow failure syndromes fall in this category. So the severe congenital neutropenia genes, Swatchman-Diamond genes, Fanconi. You've got telomere biology disorders, your RASopathies, SAMD9 and SAMD9L, which predispose to Mirage and other syndromes. And then you also have a subgrouping of genes which were more traditionally known as solid tumor predisposing genes, that we've also found that in addition to just solid tumors, they also increase risk to hematologic malignancies, and in particular myeloid neoplasms, and these may be seen as secondary malignancies or primary. So CHEK2 and the BRCA1 and BRCA2 genes are good examples of these, but you can see there are others as well. In addition to this, I've included the emerging disorders category. So these are genes for which deleterious mutations have been reported to be associated with myeloid malignancies. but there's just not as much robust evidence yet compared to the other genes to put them in a specific category of their own, but they're definitely ones that we would still consider to be clinically important. So the variety of different genes that I've shown and talked about are also involved with a lot of different cellular processes, so it's not a uniform thing. We found that pathogenic germline mutations associated with these hereditary hematologic malignancy syndromes can affect protein products that are involved in a variety of different cellular mechanisms. So for example, CEBPA, ETB6, GATA2, and RUNX1 are transcription factors that localize primarily to the nucleus, whereas TERT and TERK both constitute subunits of the telomerase complex and also localize to the nucleus. DDX41 is an RNA helicase that localizes to the cytosol. SRP72 is a ribonucleoprotein that's involved more in signal recognition, RNA binding, cellular trafficking, and for others that are well known to be associated with platelet dysfunction and hematologic malignancies like ANKR-E26, the exact function of these genes is not as well known, but we're still learning more and more about these. So it's a wide variety of scope, as you can see. Now, what I want to do next is just jump into some examples that highlight the importance of these genes and some features of some of the more common ones that you may come across, and ones from just different categories. So this is an example of a family that I've seen who are known now to have a germline DDX41 mutation. This particular variant is sort of a start loss variant known as the M1I mutation, which is the most common DDX41 variant seen in Caucasian populations. So this was first uncovered to be the cause of this family's, as you can see, high rate of AML when this individual came to attention. So this individual has an identical twin sister, and their sister unfortunately developed AML a couple of years prior to our patient's presentation. At the time, our patient was healthy and was actually chosen to be an allogeneic stem cell donor for their sister. Unfortunately, the sister who received the stem cells that also contained the same variant that caused the sister's leukemia in the first place ended up passing away from relapse disease. Whether it was donor-derived or not, we did not have that information. Our patient then subsequently 2 years later developed AML themselves. When we talked about and asked around family history, as you can see, it was very striking with 2 other siblings in that family having AML as well, their mother having AML, there was a maternal aunt with AML, and then others from those generations further down, as well as an ALL case. So strikingly abnormal, hence germline genetic testing was performed and identified the DDX41 variant. And there's a couple of things that we can see from this case. So in of itself, the original history of the sister at age 65 having AML, if you did not know the family history or anything else, a lot of people wouldn't necessarily blink an eye because that's a fairly typical age. But when you go through the rest of the history, there's of course far too many members. And as you can see in general, as generations went by, diagnoses began to occur at younger ages. We'll talk a little bit more about that in a bit. So what do we know about myeloid neoplasms with germline DDX41 mutation? So there's actually been a few big publications just in the past couple of years about this. And as you can see, this diagram is showing the DDX41 protein. And all of the variants on the top bar here are germline variants. And all of those in red are known to be causative variants or pathogenic, likely pathogenic variants. The variants on the bottom are secondary somatic variants that have been found in these cases. The most commonly found germline pathogenic variants have been the M1I variant, as well as a frameshift, the D140 frameshift variant. This particular study was conducted as a US study, so this was a primarily North American Caucasian population. You can also see that a very common secondary somatic hit is the R525H missense variant, as well as another missense variant quite nearby in the helicase domain. but you'll also have a smattering of other missense variants that can be associated as a secondary hit. One of the important takeaways, and you can kind of look for patterns, is that frameshift truncating mutations can be seen certainly as causative germline variants, but they are rarely, if ever, seen as a somatic variant. So if you have a patient with MDS or AML, and they are identified as having a frameshift variant in DDX41, you need to presume that that's germline until proven otherwise. These germline variants that are the original event in these individuals as they're born with it predisposes to the acquisition of a secondary hit in DDX41, which commonly occurs prior to the onset of leukemogenesis. The R525H is one of the most common secondary hits that's seen in this gene. Interestingly, around the time that this study was done, there was another being done that was multinational, involving 7 different countries across the world, which was a mix of ethnicities, but about half were Asian, Japanese in origin, and then there's a mix of others. So this is showing the same protein structure, but as you can see, here we're now having a high incidence of different types of pathogenic DDX41 germline variants. So in particular, you have a different frameshift variant here, the A500 frameshift, and then we're seeing as well a missense variant. And this is driven primarily by the Asian population. And so what's this showing is that the type of germline DDX41 variant differs between various races. But if you look on the somatic side, it is still that R525H variant that is the most common, as well as other common missense variants. So the ethnic predisposition for the germline variant does not seem to impact the somatic secondary hit. And interestingly as well, a difference between a primarily Caucasian population and Asian is the type of variants. So the loss of function variants are most common in Caucasian populations, and rarely do you see missense germline variants, although they can occur. Whereas in Asians, it's more 50-50 between the two. So something to think about too, of course, when you're evaluating patients in terms of what potential variants could they have, is what is the ethnic background. So why harp on DDX41 so much? Well, certainly you could see by those last 2 protein diagrams, there's just a lot of dots on there, meaning that there's a lot of patients who have this germline variant. So these are the 2 main studies that have been done recently. And within those 2 studies, they took a large population of individuals with myeloid neoplasms, and they were not pre-selected based on age or family history or known to have an underlying germline predisposition. So they just took a cohort of patients with hematologic malignancies, the vast majority of which were myeloid neoplasms, including AML, MDS, as well as MPNs, performed targeted panel MDS sequencing on all of them, and looked to see what kind of variants and what genes were found. Well, out of all of those, the rate of hits for DDX41, specifically pathogenic germline variants, ranged between 1.2% in one study to 3.2%. So that's for all myeloid neoplasms. That's a high rate. Out of all of the ones that were found to be germline predisposed, including any of the potential currently known germline predisposition syndromes, 80% of the germline predisposed MDS and AML cases were found to be due to DDX41 variants. Interestingly as well, and this is important clinical implications, is that individuals with AML or MDS with a causative DDX41 germline variant behaved clinically distinctly to those who were wild type for DDX41. So this suggests that DDX41 is a unique clinical entity for AML and MDS. So some of the features, so really the ones to focus on here is in the top row. These are the individuals who have a causative variant in DDX41 in germline, and in comparison to those with wild type DDX41. So as you can see, for those with the causative variant, males were much more commonly affected than females. And this has been consistent across a number of studies. There's a very, very strong male predominance, despite the fact that the presence of these variants in the population is equally distributed between males and females. The disease manifests more in males than females. Also important is the median age of onset of the myeloid malignancies is in an older age group, 69 being the median, which is comparable to wild type cases. So it is not your classically, when you think about something that is familial or inherited, must occur early on or younger in onset, that's not the case for DDX41. The genomic profiles of malignancies themselves is unique compared to wild type AML, commonly seeing secondary hits in DDX41. And importantly as well, we're seeing differences in median overall survivals compared to wild type. So despite the fact that we do see high rates of early transformation from MDS to AML in DDX41 carriers, especially those who have a truncating germline variant, the overall survival does not seem to be significantly impacted by that and seems to remain favorable compared to wild type DDX41. This favorable overall survival is actually not impacted by our traditional risk factors. So it does not correlate with our IPSS or IPSSR scoring system. It wasn't even impacted by usually a horrible prognostic marker in multi-hit TP53 variants. We're not exactly sure why this is. It does seem that these patients have high rates of good response to hypomethylating agents. That could be part of the picture, but we're not sure with what is the whole picture. So just to sum up on there, what is the usual phenotype for these patients? Well, clinically, if you're just seeing this patient with walking around with the DDX41 germline variant without any malignancy, so a healthy carrier, they don't have any specific clinical phenotypes. They don't have a syndromic appearance or otherwise. Occasionally, though, they could have a pre-existing cytopenia that could be present for years prior to diagnosis, potentially. If you do a marrow on these individuals, they typically have a normal karyotype, even at disease presentation. And unlike most MDS, which tends to be hypercellular, they tend to be hypocellular. AML and MDS are the most common malignancies that occur with DDX41, but we've also seen other malignancies like CMML. They have been found in myeloproliferative neoplasms, in B-cell lymphomas, and there's a question about a potential link with solid tumors as well. And there's work that's currently being done in this area. As I mentioned, the median age of onset is at older ages, comparable to standard AML or MDS. And what is the rate of malignancies in these individuals? Well, it's high. It's about a 50% lifetime risk of developing a myeloid malignancy. It's very rare for that malignancy to manifest under age 40 and typically really starts to occur after that age. All right, so let's talk about a different one with a little bit of a different flavor. So this goes back to the original one that was found that kind of spurred interest in the field in the first place. So this is familial platelet disorder with propensity for myeloid malignancy, or FPDMM, which is caused by germline ROX1 variants. So this is just highlighting a couple of different families that I've seen who were affected by germline ROX1 variants. So in the first family, the individual was diagnosed at a pretty young onset age of MDS and had a lifelong history of pre-existing low platelets. And we went into the family history. There's also family members with low platelets and bleeding tendencies, and the individual had a significant family history for MDS as well. And they were ultimately identified as having a pathogenic missense ROX1 variant. Another family, we saw a very early onset MDS at age 7 years, and a family history, again, more significant for thrombocytopenia and a bleeding diatheses. And then a great-grandparent with CMML at an otherwise older age, identified, and the disease segregation with another missense ROX1 variant. So what is RUNX1? So RUNX1 encodes the DNA binding subunit for a core binding factor transcription complex and is therefore essential in normal hematopoiesis. So it's involved with hematopoietic cell differentiation, cell cycle regulation, as well as ribosome biogenesis. RUNX1 germline variants have been found to come in all different shapes and sizes. So this is a diagram again showing the RUNX1 protein, and both above and below are found to be pathogenic or likely pathogenic RUNX1 variants. And you can see all different types are there. So you have deleterious missense variants, frameshift variants, splice sites, nonsense, as well as copy number variants, all of which have been determined to be pathogenic or likely pathogenic. RUNX1 is a bit interesting too, because both loss of function variants as well as gain of function variants have both been found to be pathogenic and associate with myeloid malignancies. So the characteristics of this disease are interesting as well. The clinical presentation can be quite heterogeneous between different variants and even within the same variant in different family members. Most common phenotype is easy bruising and bleeding in these individuals. About 90% will have a history of this. What's been coming out more recently and found to be quite common as well is an atopic type presentation or history. So eczema, psoriasis, allergies are very common in these individuals too. And there's a potential link with general gastrointestinal issues as well. So like GERD, IBS, and other issues. Clinically and on the laboratory side, typical is just a mild to moderate thrombocytopenia with an average platelet count around 120. The platelets on the CGC on differential look normal. They have a normal mean platelet volume, but on platelet aggregation studies, this will be abnormal. They typically have an aspirin-like pattern defect on platelet aggregation studies. And patients can be misdiagnosed. For example, I just saw a patient earlier today who thought since the age of 2 that they had Glanzmann's thrombocythemia, but in fact, they have FPD-MM, as do other family members. If you were to do a marrow on these patients, the megakaryocytes, as pictured here, are atypical in appearance quite often, but not frankly dysplastic. The importance is different to know, especially if you're questioning whether or not a person has developed myelodysplastic syndrome. The malignancies that these predispose to include MDS, AML, as well as ALL, with T-cell ALL being the most common, and we've seen it in a smattering of other malignancies as well. The age of onset for malignancy is quite variable for FPD-MM, from as early as 2 years to 77 years old, but on average, they tend to present in the 30s or so. The lifetime penetrance is also variable, but can be upwards to 50%. So it is, again, very important to know about. There's one other syndrome that I want to mention here as well today, and this is the GATA2 deficiency syndromes. So previously, there was a number of different syndromic entities, monomac, Hamburger syndrome, form of congenital neutropenia, DCML, but we now know that they all fall under a single genetic disorder, and that is due to germline GATA2 variants causing a GATA2 deficiency syndrome. GATA2 itself encodes for an important zinc finger transcription factor that is essential in a number of different processes, including normal hematopoiesis, but as well autoimmunity, inflammatory and developmental processes. And therefore deficiencies of this gene, we see multi-system manifestations. The malignant penetrance of GATA2 deficiency is also quite high. So upwards of 75% of individuals will develop a myeloid malignancy in their lifetime, and it typically does occur at a younger age. Patients with a GATA2 deficiency can first present with myeloid malignancies like CMML, AML, or MDS, or they may present with a sort of in-between phase of hypocellular marrow, not quite meeting criteria for MDS. It's quite common to see on the somatic side monosomy 7s or trisomy 8s with these individuals, as well as ASXL1 somatic variants are commonly seen at the time of MDS or AML development. Clinically, these patients may have characteristic findings. So lymphedema, as pictured in the upper panel here, can be quite pronounced, as in this case, as well as cutaneous warts. So warts on any part of the body, you can even see them zoomed up. There's involving of the legs, but the hands and feet, genital warts are also common. So HPV-related viruses and other viral infections as well. Unfortunately, the prognosis for these patients is not great if they are not appropriately picked up and managed. Patients develop a manifestation, often infection is the first manifestation, quite early, median age being around 20, that patients will present medically in some fashion. After their presentation, their survival begins to rapidly fall off, particularly if they are not transplanted. With transplant, the story can be different. So what do these patients look like? So we mentioned lymphedema, warty infections. They can also have a sensorineural deafness. Non-tuberculous mycobacterial infections are not uncommon. Pulmonary alveolar proteinuria, frequent and severe viral infections as well. And this is due to immune system deficit. So you'll see a low CD4 to CD8 ratio in these individuals. They often have very low NK cells, monocytes, and macrophages. And these can be seen with flow cytometry and specific panels designed for looking at these patients. The most common malignancies seen are AML and MDS, which are often in association with monozomal 7. And the average age for malignancy onset is 29 years. But again, the median age of presentation is a bit earlier than this, 20, with the most of those presenting with infections, but some also where their primary presentation is unexplained lymphedema. And as previously mentioned, the malignant penetrance is very high. So how common are these, as we talked about? And this is one of the questions that we sought to answer. So we know that MDS in general, the incidence dramatically increases with age, and it's relatively uncommon as a disease entity in younger age groups. So the low-hanging fruit originally was, well, how common are germline variants in these young or atypically young patients? And we know from previous studies that those rates go anywhere from about 13 to 19% of those young individuals were found to have pathogenic germline variants, particularly in age under 40. But what about everybody else? I've already shown you that DDX41 is the most common germline variant that we see in myeloid malignancies, but it typically doesn't present until older ages. So that's what we wanted to look at. So this is the workflow that we used for variant identification and confirmation. So what we had is we had 404 matched pairs of siblings and the transplant recipient who had MDS. So 404 MDS patients and 404 of their related donors we had peripheral blood samples from. We performed an augmented whole exome sequencing panel on these and looked for both SNVs and CNVs and curated manually for each individual variant using the ACMG and EMG criteria. And we used secondary validation techniques for any pathogenic or likely pathogenic variants that were found. In this study, we called a variant as germline as opposed to somatic, only if that identical variant was present in the blood of both the MDS patient and their related donor, or if the variant had an appropriate variant allele frequency and had only previously been reported in germline tissue. So what did we find? So we found that the frequency of germline variants, of course, is a bit higher at those younger age groups, which is not unexpected, but it never dropped to 0. And in fact, it never dropped below the 6 to 7% mark at any age decile. So overall, across all age groups, we found that 7% of all MDS patients, and these were just patients that we had no idea what their family history was, they were not pre-selected. So 7% of all patients had an underlying causative germline variant. And interestingly as well, 5% of the related donors also had a predisposing germline variant. It's important to keep in mind as well that this 7% figure is most certainly an underestimate of what the true frequency is. And this is because we only called something germline when it was shared between the donor and the recipient. And that basically means that there's a 50-50 chance, of course, that that related donor could carry it or not, even if it was germline. Sorry, I'm not sure why my slides are skipping ahead like that. Other things that could impact the frequency is that we were using a hematopoietic tissue for sampling, and this can undergo somatic reversion, which could eliminate us being able to see some of the germline variants. And some of the relatives who may have had a germline variant may have been excluded as a donor because they had their own phenotype that precluded it. So they could have had an underlying thrombocytopenia or other features that excluded them from being a donor. We were also very conservative in calling variants, and there are many suspicious variants of uncertain significance that we found that we did not call and include in this number. These highlights the type of different variants that were found. And what we did identify is that when you group based on types of variants, that the age at diagnosis of patients is really a surrogate for what are the affected genes and biologic pathways. So those who presented at the youngest ages were found to have mutations in bone marrow failure genes. Whereas those at the oldest ages, DDX41, again, being quite common, but also seeing ones in general tumor predisposition genes, as well as telomere biology genes, all at older ages. These figures do not include the presumed germline variants, and presumed germline variants are ones that we just could not say as confirmed because they were not found in both the recipient and their donor, but where other labs would commonly report them as germline because they had only ever been seen that way. And they were strongly suspected. So in terms of the presumed, we also saw 5 GATA2 variants, 3 RUNX1, a couple extra DDX41, 2 P53, and some single variants in other genes. So these were not included in these figures and numbers. So again, these are common. So if these things are common, how should we approach it? So how do we screen patients? Who should we be sending for testing? And how do we test them? So for screening, really all patients who present with a myeloid malignancy or unexplained cytopenias should be screened in the sense that you are asking a thorough family history and personal history for everybody, and doing a head-to-toe appropriate physical examination, keeping in mind some of the syndromic features that can be seen in some of these syndromes, as well as the features in personal and family history. So after you do a thorough assessment of your patient, the question then becomes, who would warrant further germline testing? So I would say certainly anybody who has a myeloid malignancy or unexplained cytopenias, and they have any of the known hereditary hematologic malignancy syndrome manifestations, like those associated with GATA2 or underlying platelet dysfunction or abnormalities, those who have a personal history of multiple malignancies, as we've seen some of these genes predisposed to multiple different types of malignancies. And for those who have a first degree or multiple second degree relatives with compatible histories of myeloid malignancies, cytopenias, or bleeding diatheses. If patients have had variants found on their standard aspirate testing for what is considered sort of a somatic panel, so those would be ones who have been found to have variants in CBPA, RUNX1, TB6, GATA2, or other genes that might be on your panel. Maybe DDX41 is on that. So any that are found on there, those should be tested further to see if that is actually a germline variant. Any first degree relatives, of course, of a confirmed case, if they are interested in being tested, should be. And I would argue as well that all MDS patients that are planned to undergo an allogeneic transplant should undergo testing regardless of their other personal or family history, given that high frequency. So that's higher than the rates of familial breast cancer, for which regular testing is recommended in those age groups. So how do you go about testing them? The key is we need germline tissue. And because these are blood and bone marrow cancers, peripheral blood, of course, is contaminated by tumor cells, and DNA, if we test it, is going to be testing their malignancy as well. So we need tissue that is unaffected by the blood. So for this purpose, the gold standard are cultured skin fibroblasts. The turnaround time for this testing is usually around about 2 months. Sometimes can be a little bit quicker, sometimes a little bit later. So it's important to try to do it at the very outset of the diagnosis. What about if you don't have that kind of time? Well, you can use alternative sources. They're not ideal because they all have potential risk for potential contamination with blood cells, or they have all other issues intrinsic as well. But for truly urgent scenarios, if you find the right variant that's not really seen in a somatic setting, buccal swabs, saliva, if you do a direct skin biopsy without culture, some places do that. The risk with that, of course, is when you do a biopsy, there's some bleeding. And so without culturing, there's still going to be some blood contamination, whereas the culturing washes that away. You can also, for expediency, evaluate a patient and related donor simultaneously if the level of suspicion is high enough and everybody's been appropriately counseled. Other potential tissue sources of germline DNA include mesenchymal stromal cells that can be cultured from bone marrow, hair bulbs, as well as tissue from unaffected organs. And how do you test? So the key as well is knowing what test you're sending them for and making sure it is a comprehensive test. So you can use exome platforms now, or there's also common panel-based NGS testing, but you want to make sure that whatever panel or test you're using has the capabilities to detect both single nucleotide variants as well as copy number variants, and that it is comprehensive and includes all the genes that you are suspicious looking out for and all the genes that could be included. Single gene testing can be done if you have the known familial germline variant, and if the individual is unaffected by malignancy, of course, in those cases, then a blood test can be used, which is easier and faster. So what we have to set up here locally at our lab in Halifax is two different panels. Some of the genes overlap between them because some of the genes can predispose not just to myeloid, but also lymphoid malignancies and vice versa. So this is a customized NGS panel-based test for which we've also included extra spiking probes to cover known, typically non-coding regions that are hotspots in germline variants. And we do this right now on an XC 2000, and our minimum coverage depth is 50x for adequate germline coverage, and we can call both SNVs and CNVs. And our panel content is reviewed on a regular basis and updated whenever there's new important findings found. This is a test that's covered for all of our patients in 3 different provinces locally. And then for outside provinces, we offer it to just costing back to the province of origin. And a little bit different than I know how things work in the US. But this is something that if anyone else in Canada is interested in having testing done, it can be done at our lab. And in the past, the provincial health authorities in some cases have covered. So that's something to think about. So the research pipeline that we've established here is we routinely screen all new MDS and AML patients for any potential risk factors. We also evaluate match-related stem cell donors and look for strong personal or family histories. So for those cases who are deemed to be at risk or warranting further testing, they get a meeting and pre-test counseling, discussions. We take a sample of germline tissue, and that is typically, we perform a 3mm punch skin biopsy, culture it, grow and isolate the fibroblasts, isolate the DNA, and run our local panel. The panel comes back positive or negative. The patients get post-test genetic counseling and clinical site-specific testing if needed, as well as familial tracing. For those that are negative, they go more into the research pool and go into a pool for research-based whole exome or whole genome sequencing. And any results that we get back from our testing are fed back into our clinical pipeline to try to optimize our testing platforms. So that was a lot, and in a short order, I want to leave time for discussions and questions. So I just want to leave you with the take-home messages here is that there are a lot of newly recognized hereditary hematologic malignancy syndromes, and there's more that are continuously being discovered. These syndromes are a lot more common than was previously thought. You think about that 7% rate, and that is a bare minimum. When we included those presumed germlines, that increased to 11%. When we included the highly suspicious VUSs, that increased to 12%, and that is across all ages. So certainly that rate would warrant routine testing for all transplant eligible MDS patients because the rate in the related donors was also high. And these patients are just being transplanted back, the same variant that caused their disease in the first place. in order to achieve these types of goals, we need to try to increase the availability of testing throughout Canada, as well as the rest of the world, but Canada in particular lags behind a bit in this type of testing and for coverage. So I certainly want to reach out to any colleagues as possible. We want to try to get this going. So thank you for everyone for joining today, and I'm happy to field any questions at all or just open up to discussion as well.
Thank you, Dr. Trottier. I first want to just mention that I actually had a phone call from a hemopath during your talk about a DDX41 that I reported, and he wanted to know, why do I know that one of these variants is germline? And the second variant was R525H at 1.5%, and the first variant was a frame shift at 47.5%. So I just had a quick conversation about that to come back to your talk, but I wanted to mention how important this is. And we have tons of questions. So I first wanted to ask you, you mentioned that the penetrance is actually really high for DDX41. You said 50%. Do we have any studies that show penetrance varies between variant? Like maybe some of those variants that are missense have a less penetrant family history, or is it just in general that we know 50% is the number that we should be spitting out?
Yeah, we suspect it varies by variant, but we don't have specific numbers for it. Some of the evidence that it does is that the penetrance does seem to be even higher in the Asian population. And they do have, as I mentioned, unique variants compared to the Caucasian. So those were actually higher than 50%. So 50% is actually kind of the lower end of it. And that penetrance is age dependent as well. So that's the overall lifetime. But it's very significant. Yeah.
Okay, so to some questions. What about deletions of DDX41? Have you encountered any of those large exon or full gene deletions?
Yeah, so I haven't seen one myself, but I have seen recent reports of one that is questionable. So I've seen one that has been a large deletion, including DDX41, and the patient has developed myeloid malignancy. And so that is very highly suspicious, and it makes sense because one of the main ones is truncating variants in this gene. So presumably. And I'd bet a lot of those are missed just in general, because typically the CNVs are missed much more often.
And that's a second point. If you had a case with a common second variant and you couldn't find the germline variant, what do you do to recommend for those patients?
Yeah, and that is a good question. And that one is trickier to answer because there are also cases that have had pretty comprehensive testing where we see a somatic variant that is often associated with a germline variant in the absence of a germline variant, so somatic only. And in these studies, they actually seem to behave clinically differently than the germline DDX variants. So certainly those cases can happen without a germline variant, but there might be some cases where there's one missed. So in those cases, you really need to review what the testing you had was, and was it truly comprehensive or not? And if not, then I would seek out more comprehensive testing as the first step.
Interesting. So one of our attendees was asking, can you elaborate on the saliva as a germline sample? Why are you saying that that's not the best case to use?
Yeah. So the goal is that in saliva, you're getting some of the buccal mucosa, the epithelial cells, and that should in theory be germline. But there's actually been work done looking at saliva samples and the rates of somatic tissue and blood contamination, and it's not insignificant. So white blood cells have been found in it, as well as even red cells in individual spit. And so you do get a bit of a mix. So you can't be 100% sure that all of that DNA is germline, because you will have some hematopoietic cell contamination. That being said, I use it myself for patients who are more remote and can't have a skin biopsy done, but I am always aware with caution that it is not a true gold standard.
Got it. This one's an interesting one. I'm glad another attendee asked this. Given the prevalence of germline conditions, is testing for donors, those who are going to give be a part of the donation process for bone marrow transplants, increasingly important?
Yes, very good question. Very contentious question. So you will find people are strongly opinionated on that. And there have actually been questions posed, even in the literature, is that, have we reached the point where universal donor testing is appropriate? And as you could see, it's pretty alarming, the rate of those related donors who had variants. And again, there's some who were probably excluded. So those were related donors who were otherwise deemed perfectly healthy and suitable for donation. And the consequences are high. So I am personally on the camp where I think there should be universal testing. Of course, very important is those individuals need their own dedicated counseling beforehand to understand those potential ramifications. But just in knowing how high risk transplant is for morbidity and mortality, you want to make sure you are doing the best for the person from day one. So if you're starting with using a donor that has a risk of giving person back something that can not only give them a donor-derived leukemia, but affect things like engraftment rates, time to engraftment, and increase morbidity or mortality, for those reasons, I think it should be done.
And I'll tell you this, I've actually had a MUD donor, so a match unrelated donor, and they were positive for DDX41. So yes, when I tested the patient again, that was a very sad case.
So stay tuned. We are working on an expanded cohort beyond the related transplant population to the unrelated group. Because if you also think about it, the unrelated transplant donor pool is a biased pool.
It is.
Because most people, everyday Joe, is not a bone marrow transplant donor on the registry. They probably don't even know what a bone marrow transplant is. So a lot of people who sign up on the registry are because they have some kind of personal connection as well. But these rates in the population are high enough, so yes.
Could you comment on the role of concurrent RNA on improved identification of individuals with hereditary cancer predisposition?
Sorry, I missed the first part of that.
Comment on the role of concurrent RNA testing. So if you're considering that in hereditary.
Yeah. So, I mean, that is really important and next level too. The reason why I think it hasn't been done as commonly now is just that it is more labor and cost intensive to do that. But that is something that we're looking at now. And some of the studies that I'm doing right now are combining RNA-seq as well with genome and exome data to see what are the actual expression differences through protein differences. Yeah, it's just not as available on a clinical basis.
Is just a quick question on your panel, or speaking about panels, is 50x coverage sufficient to detect those variants using your panel?
So 50x for us? Yeah. So that is, most of the genes have more coverage than that, but 50x is established as it has to be this at the minimum. And because we're looking for germline variants, it is considered to be sufficient because we're looking at things with VAFs typically around 50%. So you will have enough reads on a 50x coverage to be able to see something that is at a VAF of about 50%. You will not find, for example, on that covered panel, a low frequency somatic variant that's only there about 1 or 2% of a clone, but that's not what we're looking for.
A quick question on leukemia type. So if you had a patient, is there a particular type of leukemia where you think a skin biopsy would be need to be done at the time of diagnosis? And I've heard about this done while they're taking the bone marrow biopsy.
Yeah. So I've done this as well. So for any person, well, now I try to do it in all the MDS and everything like that too. But if you have an individual who has risk features, at the time that they're having the bone marrow, you're creating a sterile field, you're anesthetizing it, you're poking a hole, just take the skin biopsy at the same time and do it concurrently. And it's much better to try to do it before the patient has been given, for example, induction chemotherapy, and infection risk is high, and everything else. So the sooner the better.
Also, the cells don't tend to grow.
Exactly. The biopsy doesn't culture as well when they've got anthracyclines in their system and things.
Excellent. We have so many questions. I'm going to try to get through them. Have you seen chip-related alterations in carrier individuals at younger ages? How frequently and how do you follow them up?
Yeah, so that is also another very good question. And chip is absolutely seen in some of these syndromes and in some in more than others. So RUNX1, for example, is one that we find chip in these patients. And they tend to be in specific genes, and some of them don't seem to correlate with disease progression, whereas others are harbingers, like, oh, once we see this somatic variant arise in this gene, they're going to transform soon, where others tend to be more just sort of passenger variants and they acquire chip. So that's something that's really being looked at in a number of the different syndromes, but definitely yes. And there's some articles now that are focusing specifically on that. We're also looking at rates of chip and things like those related donors as well, who don't have malignancy, but we're being used for transplant.
And speaking to RUNX1 mutations, can you elaborate more on the mentioned gain of function RUNX1 mutations?
On the which one? Sorry, the gain?
The gain of function RUNX1 mutations.
Yeah. So it's interesting because there's both, as we saw, gain and loss of function variants, but both of them can manifest as the same disease. So the mechanisms for it are not yet entirely clear, because sometimes we have those genes that may predispose to different types of diseases, or a different one may be more proliferative and one may be more hypoproliferative. But to be honest, we're not really sure.
Interesting.
It's more than this one still that result in the gain.
Yeah.
One. Yeah.
In your clinical myeloid and lymphoid panel, do you recommend reporting BRCA1 or BRCA2 pathogenic germline variants if heterozygote without a second germline variant? So do you think the monoallelic BRCA1, BRCA2 are involved in MDS AML onset?
100%. Absolutely. And in fact, for individuals who have a history of breast ovarian cancer with a BRCA1 or BRCA2, their rates of secondary myeloid malignancies, so they've had their chemo or their treatment, is much higher. So we see those therapy-related myeloid neoplasms. There is very high rates of those therapy-related individuals have underlying BRCA1 or BRCA2 heterozygote variants. And we've even seen patients in the absence of primary breast developing a myeloid neoplasm as well. So yes, definitely. And I counsel those patients appropriately. So those patients, when they're treated for their breast cancer, are at much higher risk of developing a therapy-related myeloid neoplasia than a breast cancer patient undergoing the same treatment without that variant.
Interesting. And I'll say this, one of the attendees actually brought up another important thing. Beyond germline testing, they mentioned that they actually had a donor that had a deletion of 20q in their bone marrow, and the donor later ended up showing with MDS. So maybe it's beyond germline testing, right, that we should be looking at this.
Yeah, definitely. And there's always the question too of what harm are you doing to donors by giving them agents that stimulate production of their stem cells to harvest. So you're abnormally turning over their stem cells at a higher rate than normally. And is that increased stress? Is that enough to push a predisposed person over the edge to develop a neoplasm themselves?
I think the problem is the cost, right?
Yeah.
So that's the big problem that we've all heard from. So we are close to the end. So I just wanted to say thank you, a big thank you for presenting. I was very excited to hear your talk, and I know there are so many people here that were excited to hear your talk. We will have this recording available on our website eventually. So for those who have asked in the Q&A about the sharing of slides, you will be able to watch the video again and share it with your colleagues and residents. Finally, again, there's an evaluation, the link to the session evaluation if you're looking for your CEUs. And the webinar code for PACE credit is also listed there. So please look at your chat. Thank you again, Dr. Trottier, and we're very appreciative.
Oh, my pleasure. And I'd say if anyone is more interested or has other further questions offline, feel free to reach out to myself, or if any one of my Canadian colleagues is interested in utilizing our panels and question for coverage. We have been successful in other provinces in getting that covered. So again, just reach out. I'm happy to help in any way that I can.